It's a real privilege to introduce Dr. Rashid Kumar, and I don't want to sound like cliched, but he is Pakistan's best neurosurgeon. His father was a legendary, iconic neurosurgeon in Pakistan. He was one of the first neurosurgeons in Pakistan. And I often talk to physicians from that part of the world, and they'll tell you how his dad took such good care of some families like 30, 40 years ago. Dr. Jooma is now a professor at Aga Khan University, which is arguably one of the best medical schools in Asia. He trained in England, did a fellowship at Memphis, and really had a huge practice there. And then he did, what few of us can do. He was called by the health minister to be the equivalent to the Surgeon General of Pakistan. So he really was in charge of health care for a population of 200 million people. And so he brought what he brought to neurosurgery, which is a keen and perceptive eye and an empathy to improve and help people's health care, that he brought that passion to it. And for 3 years, he worked with the president and the health minister in ameliorating health care there. So he's a fabulous surgeon, but he's a public health official as well, and has really made groundbreaking changes in the healthcare of Pakistan. And on the lighter side, he's the captain of his golf team in Karachi, and he's a very good golfer. So without much further ado, Dr. Jooma. Thanks. Thanks
for Anil, thank you very much. And that's exactly what I found myself in, with the change of roles from being a practicing neurosurgeon to being a public health specialist. I spent a lot of time thinking about how one extends healthcare to large populations. And coming from a country where this was a great challenge, I spent a lot of time, and I just wanted to share my thoughts and my information on this. There was a commission on health economics set up by WHO in 2000, headed by Jeffrey Sachs of Columbia. And they made the case that if you can improve health, you can improve the economy. And this was supposed to be the case for governments to invest more in health. And this is true, but if you really analyze this well, as was done by a group at IMF, it's a very slow process. And the other case, of course, which was made so well by John Rawls, the philosopher at Harvard, is that it's also a moral imperative. And that's something that I really strongly believe, that nations have to make choices about the healthcare that they're going to give their citizens. But despite that, there is huge inequalities, and that slide shows you the spending of healthcare in low and middle income countries. And you see that it's actually a huge scatter. And so obviously the moral imperative or the political motivations are quite variable. And you see this also in another way, in as much as even within countries have similar resources, the facilities are varying. So one very common public health measure is how many women use the skilled birth attendant when they have their delivery, and it's a very important parameter and a very important measure. And you see that if you plot that against total health expenditure per capita, you find that you can have very good attendance records for women in countries with low incomes or low expenditures, whereas the opposite may also be true. And this has something to do with how good your health system is, or at least how good is the utilization. And in fact, if you look at utilization rates, then those are quite varying across nations and across countries. And your ability to reach the MDG goals, Millennium Development Goals, that pertain to maternal child health and general well-being are kind of predicated on how much investment you make in your public health system. So in fact, what we have is a situation where health systems for the poor tend to be poor systems, and people with the most means consume the most health care. But what's really important is that even the resources that are allocated are sometimes badly used because they're clustered around high-end urban-based projects and healthcare centers, whereas in fact what we need is to concentrate on where the real disease burden is, and that's in the preventive and promotive sphere. So if you look at financing options that are available, you can either be entirely or considerably out of pocket. I need to get a glass of water.
Oh, sure.
A Coke?
Yes, sir.
Thank you. Thanks, Robert. So you can either be largely out of pocket or the Beveridge model. And Beveridge was a Labour politician in England who after the war was tasked to cast the UK's health system. And the national health system was a creation of the Beveridge report. And it's an entirely tax-based system. The government pays up front and everybody has free and good health care. Or there's the German model, and in most countries it's mixed. So what you have actually is a situation where you're either, like in India, largely out of pocket, or you're in UK depending on a tax-based system, or you're in Costa Rica where you have a social insurance sponsored by the government, or you're in the US where you have the mixed system that exists here. But whether you have an efficient system that affords protection to your population depends very much on whether it's considered a human right. And this may seem intuitive, but actually there is a wide variation. One of the things that Pakistan and the US have in common is that neither country accepts a right to health as a constitutional right. Which means it's not legally enforceable. And so the WHO Charter says that all nations and all peoples should have health care, and there are other declarations, but only a number of countries have it as a constitutional right and others don't. And of course the other thing is how much you're willing to spend. And I just want to share with you that Pakistan's expenditures are low. The one to concentrate on is what the total health expenditure is as a percentage of GDP, which is about 3% in Pakistan. It's about 20% in the US now and climbing. But you cannot have a health system that functions unless you get up to levels in excess of 10 or 12%. And what's more important to track is where that money goes. I'm sharing with you the national health accounts of Pakistan, and you can see from that orange pie that the system is largely privately generated, and what actually the state offers is much smaller, and that's in the Social Security funds and the federal government funds. A lot of it is coming out of pocket and is impoverishing, because if you look at where the health expenditure goes and how it affects people, 10% of the poor tell you that they have foregone care when they're sick because they do not have the means for it, or 75% of the poor go to private sector when they seek care, and when they do that, it doesn't come cheap because they're paying large amounts of money even if they go to a public health system. So clearly people need to be protected from this, and that protection can come from universal health care. And universal health care, which the United Nations, the WHO defined as giving all peoples unfettered access to all the promotive, preventive, and curative services they need, has 3 dimensions. And that it must have equity in access, it must give you quality across the board services, and must protect you from impoverishment. So this is the famous WHO. I'm sorry. This is the first time, Anil, that I'm using my my laptop in this mode, where I'm seeing the next slide along with this slide, and this is a nice novel experience, but I'm getting ahead of myself. So in universal healthcare, of course, the issues that you need to consider is how you're going to collect the revenue, how you're going to pool it, and how you're actually going to purchase the services. Those are the 3 dimensions. And in the cube, this is the famous WHO cube on universal healthcare. You have to trade off in these 3 areas. In other words, you have to decide what proportion of the population you're going to cover. So who's exempted and who's included, and what are the range of services that you're going to offer them, and what quantum of the total costs will you meet. And those are the 3 major considerations. And it's an evolutionary process. You start off with a population where everybody's paying for all the services they consume. Then you have mixed systems by social security contributions or your employer's contributions. And then you slowly move towards where you consolidate all that in a fashion that can give everybody the care that they need. And if you look at various nations who do have close to universal health care, it's largely based on domestic funding, and with a certain modicum of voluntary prepayment, and everybody has a small amount at the moment. All the systems have a certain amount of out-of-pocket payments, because even if you have insurance, there are co-payments that need to be made. And so for every service that you use, there's a certain amount of co-payment. And so what you want to move towards is where the co-payments are also eliminated. And it's important because even if you're insured, the co-payments can be impoverishing. And so the economists will tell you that if you're about, if the nation is below 30% out-of-pocket payments, you're reasonably protected against impoverishment. Anything above that is constantly a threat to your citizens who may be seized with an illness that will push them below the poverty line and deprive them of their assets. And this is a very important consideration. So around the world, if you look, the area in the drawn circle is where these citizens are, who don't have unfettered access and don't have the means to procure services, and when they do so at the risk of impoverishment. And the financial barriers are not the only one. There are other barriers. The cultural barriers, geographic barriers, where there's distances between provision and customers, and then to a certain extent low health seeking motivation comes in, although I really believe that that is a function of some of the other barriers that people face. But the poorly functioning and the poorly regulated health system is really at the core of poor provision. I want to share with you a slide that I was showing constantly when I was in government, that this is what our health system looks like. And it looks lovely because it's a pyramid where at the base is our Lady Health Workers Scheme. Pakistan has a wonderful Lady Health Workers Scheme, about 100,000 ladies who are tasked with domiciliary visits to their catchment area, and they report into their basic health units. There are about 6,000 basic health units, and it goes up like that, and they're providing various levels of care. But what I did not show, what I did not show in my presentations was, beg your pardon, was this slide, which was from a study about asking people why they did not use providers when the children were ill with diarrhea. And you can see it's all the things I previously mentioned. The facility is either too far or it doesn't exist, or if you get there, the medicines are ineffective or not available. And one of the big things, which I've really felt is at the core of providing service to people, is that the staff is very unhelpful. Generally, medical staff, and this is physicians and paramedics and nurses across the board, are generally not very helpful to indigent people. Lots of studies have shown that we professionals treat well-off people more differentially than we do poor people. And this is something that really needs to be addressed and changed. And a lot of studies will tell you how people are put off and from seeking care by the poor attitude at a particular facility. And of course, culturally, lack of a female staff is one of the important factors. So as nations progress towards universal health care, there are trade-offs between comprehensive packages for specific populations or providing limited benefits for the entire population. One of the countries, and I'll come back to this, is Rwanda, which obliges all their citizens by law to have health insurance, and they're up to 96%, and with a very low premium. But then the services are also limited. So Rwanda has a 96% health insurance, but it's not comprehensive, and so people still are out of pocket. But it's a start. Ghana also has a national health insurance system, which is specifically funded by a 2.5% tax on the VAT. So VAT is about 12%, and 2.5% of that 12% goes to fund this. So everybody is actually paying, which actually sounds good, but what it means is that the rich and the poor are paying the same amount of tax for the services, and then so that obviously is regressive in the way it's set up. And Thailand is something that I'll just come back to again. I want to share now some country examples with you, countries that are thought to be making good progress. I had the opportunity to visit Kenya recently this year, and they've made a very good start. They haven't got very far. They've made a good start because what they've done is, and that's this complex slide over here, what they've done is set up what you see in the middle, a health sector services fund, which the government is putting money into. And what they've done is on the supply side, they've improved the infrastructure, they've brought in physicians, they're putting the supplies. But this is very basic. And on the other side, they've linked these facilities with the communities. So the communities now have a stake in what's being offered, and so to a certain extent also serve as a quality control measure. But as I have mentioned, this is for a limited range of services, and this is the sort of thing that you see, and this is a child welfare clinic or a public health clinic in Kenya, and they're telling you what is available free, and you're getting nutritional counseling, and you're getting HIV counseling, and you're getting breastfeeding counseling, and you're getting immunization. And you're being told that this is all guaranteed wait time. So it's not much, but that's the principle that you want. The principle is that there must be guaranteed services of good quality, and that's really the way you build on these services. So coming back to Rwanda, you know, as I said, it's quoted a lot. It's quoted a lot because they've got up to that high level of cover in a short span of time in a country that was devastated by civil war. In 2000, they started off by extending cover to the civil servants and to the military, and then they expanded to the formal workers. And in 2008, they passed a law saying everybody needs to now have insurance. And what they did was they based this district-wise. So it was a small mutual micro-insurance fund based at the district level. And this has worked pretty well. Rwanda is a small country, and it's probably easy to manage. And they offered exemptions, legal exemptions to poor, to pregnant, to unwell people, and disabled people. But what was important is that they also made large investment. Rwanda jumped from spending something like 6% of total spending, government spending, to something like 17. And they did this in a short span of time. But as I said, it's good, but it's limited in what it offers. And the most important move that they made was they took away the district pools into a national risk pool. So what they experienced was, you can start off by a fragmented district-based system, but if you want to use your money in the best possible way, you have to consolidate that money into a larger pool. And this is a very important lesson, and it's a lesson that I will repeat to you. But Rwanda is a very good model of seeing how smaller fragmented pools of contributions and payments are not as good as larger pools. But anyway, they've had very impressive this thing. And what you can see there, that as their enrollment levels have gone up, their utilization levels have gone up. And Rwanda is the only country in sub-Saharan Africa that is going to meet its Millennium Development Goals next year. Just more slides of how the coverage has gone up since the mutual fund started, and how the out-of-pocket expenditure on households has gone down over years. So I just want to talk about Ghana for a little while. And Ghana also encouraged, by the way, a lot of the, it's really interesting to me that in the 1980s and 1990s, the Washington-based development financial institutions, the IMF and the World Bank, were telling countries around the world that you've got to stop spending money on health. Don't do this, this is bad. This is spoiling your economy. But that changed. But it changed very slowly, and by the time the change of heart set in, all these countries, their public health systems were destroyed. And now they have to kind of rebuild. And now the new mantra is, you've got to now provide public health care universally. And Ghana is a case in point. You know, they've actually set up a system where they had small pools for civil servants, but what they've done is they have brought in all the citizens under law for small payments with co-payment by the government. So the government says, you pay and I'll make matching payment. And that's actually worked pretty well. But Ghana's performances have actually been marred by, quite frankly, mal-reporting and a lot of corruption. And so what I'm showing you here is how it favors, the system favors middle income people, and the reporting is such that they should have been up on the top of the curve, but actually they're somewhere at the bottom. But Ghana still held up as an example and is doing well, and it's another one of the African countries that will probably, I think, within the next 10 years, reach universal health cover. The country that people talk about a lot is Thailand, because Thailand has really made very good progress. And to a large extent, this is political will. If you've been following politics in Thailand, it seems a little turbulent. There was this guy, and then the military ganged up on him, and they threw him out, and then there was elections, and his sister got elected. Well, that guy was a guy called Taskar Sirivit, and what he did was, he came in and said, 30 baht scheme, which is, you pay $1 at a state this thing, and I will guarantee that you will get treated for anything that you have. So the 30 baht scheme of universal health care was immensely popular with the rural poor, and he immediately had this huge vote bank, and he's done very well. And their thing was based on the government setting up a universal health fund in addition to what they had already, which was the civil service front and social security, and they plugged this into all of this into the public providers. The public providers in Thailand, they're very good. They have a huge network, lots of people, and so they were in a perfect place to be able to fulfill the political request that anybody who comes and pays the co-payment of 30 baht, you treat him. Over time, this been a bit unfavorable, I should say, with the medical establishment. But what the Thailand government did was to attack this by expanding the public health network, investing more and more in district hospitals and a smaller healthcare unit, and putting in staff that was non-medical. So if they were going to be opposed by the big boys and the doctors, they were going to handle this by doing nurse practitioners, and they were going to go with paramedics. And so they have actually done this quite well. And the other thing that they've done, I'm sorry this is a complex slide, but I just wanted to focus on that middle bubble, which is technology assessment. They said, we want to give you health cover, but we want to be sure that this new drug, this new technology is actually worthwhile. And so they have a very strong technology assessment unit which looks at whether a drug is actually cost effective, whether a device is cost effective, and it cannot be introduced into the national system unless it passes that assessment. And so this is quite an important thing because, you know, if governments want to do this, they obviously don't have an endless pot. And so this thing about technology assessment is very important, and it's also something that's happening a lot in the UK, which is trying to balance its budget against the expanding expense of healthcare. But anyway, be that as it may, the last slide on Thailand I want to share with you is this study, which clearly showed that if you look at what household impoverishment rates were like before and after universal health care, at least on that measure, Thailand has done very well. Clearly when you look at countries, you can either grow incrementally, like the examples I've showed you, or you can go in one fell swoop. And the country that did this in one go was Kyrgyzstan. And they started, they basically went for providing cover to the whole population at one time. They started on a health reform program which shifted from private to public provision by law. The Russian Federation had broken up, and they did this by keeping the expenses low. So if you look at Kyrgyzstan's expenses compared to the other countries around them, they have managed to do this by keeping their expenses low, essentially by having a good system of motivating health workers, by giving health workers a stake in what they're doing. So here you have the population covered is 100% with payments, co-payments for some services, but a basic benefit package and primary health care that is free for all. And they give the providers a stake in this, they gave providers a stake in this by giving them incentives for making sure that they meet these state guaranteed health services. So clearly the critical element in this is motivating the staff, and the countries that have been able to do this have a better chance at meeting this. I wanted to speak a little bit about Korea because all the other countries are poor countries with impoverished populations, low expectations. What has Korea done? Well, Korea very rapidly moved to total cover of population in healthcare, and essentially they did this by introducing a single payer system, which is a dirty word in America. They did this by introducing a single payer system. They made a single pool by consolidating the 2 or 3 systems that they had, and then they set up another company to do the purchasing. And they've been able to do this quite rapidly, quite well, and most of you have some idea that Korea actually has a very good health system, and they are really an example to this thing. And if you look at how their services have gone, it's been over time, the expenses on drugs have been pretty static, equipment have been pretty static, but the amount of money that you have to spend for services has been growing. So there is that component of out-of-pocket services that they have to do as a co-payment has been growing. So while they've gone rapidly to universal health care, it's at an expense, and that expense is, or that downside is, that there's a certain co-payment that all Koreans have to make. And there are some services for which the co-payment is high. And so it's an excellent system, but that's the black mark against the Korean system. The other country that we need to look at is Taiwan. And we need to look very carefully at Taiwan. In fact, Taiwan also went to a single payer system. And the people who did this system in Taiwan are also the people, the academics, who are advising Vermont on their single payer system. They did this very rapidly, and they did this in a way that produced equity. In other words, in Taiwan, with the introduction of universal health system, the poor has benefited the most. So this is a study of 10 years of their health system, and over time, as you look to the curve bending, this is a concentration curve, as it bends to the right, as it bends to the left, I beg your pardon, as it bends to the left, it shows you that the poorer are working these services more, or are obtaining these services more. And there is a thriving private market in Taiwan, but of all the countries in Asia, Taiwan's guaranteed service for the poor are the best. In other words, even the most impoverished can get a good, high-class cardiac bypass or brain tumor removal. Now, very quickly, the last country that I want to talk about, last 2 countries are Chile. Chile has a fragmented system, and the Pinochet government came in and made it worse by pushing private insurance. So FONASA was the national fund, and ISPRES was the private fund. And over time, as you see, the expenditure per member of the private system was always higher, and actually has tended to be higher, to the point where the courts got involved. And that's the advantage of having a constitutional guarantee. The court said that this discrimination of the private insurance against poor people is constitutionally not tenable. So the AUGE, from this study about Chile, is a state guaranteed systems for 52 conditions that was introduced. And this study looks at what is the unmet need, what was the unmet need of people before the state guaranteed system, and what is it after. And if you see, after the introduction of this, things improve, particularly for the poor. And what this shows is that judicial activism can play a very important role in bringing governments to heel. I want to just tell you my last country, which is Costa Rica, and I think I'm going to skip the slides and just tell you, I really want to skip the slide because one of the things Anil Lada told me last night was the rudest thing you can do is go over your time. And so I'm not going to fall into that trap. What I just want to tell you about Costa Rica is this, that Costa Rica in I think the 1950s, and it's probably the only country in the world that constitutionally abolished the army. Costa Rica doesn't have an army. It has a National Guard, but it has no army. In the Constitution, not allowed to have an army. So a lot of expenditure has been shifted to the people. Today, Costa Rica spends more per capita on health than any other country in the world. The total expenditure on health as a percentage of government expenditure is 28%. US is about 19%. Pakistan's about 3%. So 28%. Costa Rica, just incidentally, quickly, has the highest number of university graduates per capita in the world. So with that, they were able to, I wanted to do a Chile-Costa Rica comparison. Despite being in the same region, they have a disparity in the commitment to people's welfare. And Costa Rica has universal health care, high quality. There are waiting lines, yes, but on lots of surveys of citizen satisfaction, they come out very high. So now I just wanted to finish with the US and say that, you know, the US, we all know, is high spending, it's unsustainable. There was a recent study saying that with, you know, this slowdown and so on and so forth, the point where the median family income and the health expenditure is going to come to be par is around 2030. And this clearly is something that, and it's at a cost that is not something to be proud of. In a recent survey done by the New York-based Commonwealth Fund, the US of the OECD countries had the lowest ranking healthcare. This is the ranking that you have before you. And a lot of that money is actually wasteful expenditure. The non-wasteful expenditure of your total health expenditure is that 1.7 trillion. But a lot of it is there. Unnecessary services, excessive administrative. The administrative expenditure in the US is about 20%. Costa Rica is about 4%. So those are things, and a lot of it is the physicians. The physicians have a very important role to play in this. This is a study of, do the physicians know what is the cost of the tests that they order? It's a pretty bad thing. And there's a lot of attention to how resident education must now include cost of care education as well. We have an important role to play in this, and we will only be able to achieve a universal health care cover if I can start from the bottom. If the provision is responsible. We have to be responsible in as much as eliminating services that fee for service as a payment model. We have to be more efficient in what we do and be more professional. And then the other things are what I've already gone over with you, which is that you have to have constitutional guarantees. It's got to be a moral imperative. People have to appreciate that healthcare is a social good and it's not a market commodity. And you have to, the government has to be persuaded to increase the outlay on health. And you know, or if you look around the world, and that's what my message to you is, fragmented health systems with hundreds and thousands of insurance companies in a fragmented pool can never give you the kind of standard of care that a nation like the US deserves. Thank you very much indeed.